Hi, this is Tao Lee, Editor-in-Chief of First Aid and Usually RX. Let's shift our discussion now to talk about lung pathology. We spent a big chunk of time in respiratory physiology, so now you should see this pay off with board-testable anatomy and physiology correlations throughout this section.
Pulmonary embolus is one of the more feared complications in hospitalized and otherwise debilitated patients. You should also fear it because it's likely to show up on your boards. There are a number of things that can embolize to the lungs, causing the classic presentation of chest pain, tachypnea, and dyspnea. And they're pretty much summarized here with the fat bat mnemonic. Fat emboli are classically associated with long bone fractures and liposuction, while amniotic fluid emboli can lead to an anaphylactoid reaction and postpartum DIC. So what's DIC again? Well, that's disseminated intravascular coagulation as discussed back on page 388, where you see widespread activation of the clotting cascade leading to bleeding, bruising, and kidney failure. That being said, approximately 95% of pulmonary emboli arise from deep vein thromboses in the legs, which is why any patient with prolonged immobility is placed on some degree of DVT prophylaxis. The first step in diagnosing a pulmonary embolus involves having a high degree of suspicion. In the ER, you usually will not see too much with a chest X-ray or ECG, so a high-res or a helical CT for visualizing the pulmonary vasculature is pretty much the test of choice. Of course, you'll also want to look for signs and symptoms of DVT, which we'll talk about in just a second. Now, down here you'll notice that we have some nice images of pulmonary embolism. I just want to mention that you can have embolus so big, like the saddle embolus, that can bridge across the pulmonary artery from the heart as it divides into the right and left main pulmonary arteries. And this can cause cardiovascular collapse and sudden death, as you can probably tell since we're looking at a post-mortem example right here. Because of its association with pulmonary embolism, DVT is very high yield, and you should expect to see one or more questions about this topic. So, do you remember Verkel's triad from your hematology talks? Sure you do. Patients are predisposed to the development of DVT on the basis of venous stasis, or immobility, hypercoagulability, and endothelial damage. So in other words, you are getting inappropriate activation of the coagulation cascade. Can you think of a type of patient who is at particular risk for developing DVT? Sure, one answer would be orthopedic trauma patients. Other situations in which you should be thinking about DVT include older patients, being pregnant or postpartum, long plane trips or car trips, cancer, and birth control pills. What's Holman's sign? Well, this is where you get tenderness of the calf muscle with passive stretch such as dorsiflexion of the foot, and this is thought to be a classic sign of DVT. That being said, Holman's sign is usually not that specific or sensitive. You usually end up trying to make the diagnosis with duplex ultrasound of the extremity in question. Now, don't feel too bad if you ever miss this diagnosis, because I have a close relative who will remain unnamed who is an academic orthopedic surgeon who missed this diagnosis in his own wife who is postpartum. Now, if you make the diagnosis of DVT, how would you treat it? Well, treatment mostly involves anticoagulation with low molecular weight heparin and warfarin. This keeps the clot from expanding and greatly reduces the chance of a pulmonary embolism. Here's a case of a 15-year-old girl taking oral contraceptives whose left leg became severely swollen after a long airplane ride. As you can see, there is complete obstruction of the proximal left femoral vein propagating into the distal IVC with multiple dilated collateral vessels. So here's another huge topic for the boards, and it's a big group of diseases in general. How big, you ask? Well, COPD alone kills more than 125,000 Americans each year. That's 9/11 times 40. To understand obstructive lung disease, it's important to understand forced vital capacity and forced expiratory volume in 1 second. FVC is measured by spirometry, and it's the volume of air that can be forcibly exhaled in one full expiration. So basically, the patient is asked to inhale as much as possible and then to breathe out as much as possible. FEV1 is measured in a similar way, but is only the volume of air that can be exhaled in 1 second. Now, here's the lung volume diagram from page 561. By definition, obstructive lung disease involves obstruction of airflow, and then what do you get? You get air trapping in the lungs. During exhalation, the airways close prematurely at higher lung volumes than normal. So as a result, you get increased residual volume and decreased forced vital capacity. It's important to know that in obstructive lung disease, FEV1 also drops. Now, since FEV1 decreases to a greater extent than FVC, the ratio of FEV1 to FVC also drops, which is the hallmark of obstructive lung disease. Since these patients also have decreased ventilation due to a lower vital capacity, they have decreased ventilation and increased perfusion, or in other words, a VQ mismatch. In contrast, you will see a preserved FEV1 to FVC ratio in restrictive lung disease, as we'll discuss later on. So let's discuss COPD, asthma, and other forms of obstructive lung disease. Patients with chronic bronchitis can be thought of as blue bloaters. This is one of the most common presentations of COPD. The pathology of their disease involves hypertrophy of mucus-secreting glands in the bronchioles. The mucus and inflammation causes the obstruction, which causes the body to decrease ventilation and increase cardiac output, creating that VQ mismatch. You may also see secondary polycythemia. These patients classically present with a chronic cough for greater than 3 consecutive months per year for at least 2 years. They also have wheezing, crackles, cyanosis or blueness from shunting and dyspnea on exertion. And then you may also see signs of right heart failure, which will give them that swollen, bloated look. So when you think about emphysema and also chronic bronchitis, what's the very first thing that should come to your mind? Tobacco smoke, of course. Now with smoking, you get this characteristic destruction of airways and terminal bronchioles, classically called centri acinar, before the destruction spreads peripherally. This leads to decreased recoil and increased compliance in the lungs. And the patient will typically present with dyspnea, decreased breath sounds, tachycardia, dyspnea on exertion, and then later in the disease stage you'll see hypoxemia and eventually wasting. The pink puffer look comes from the effort to puff through pursed lips to increase airway pressure and to prevent airway collapse during exhalation. Now there are a couple other morphologic types of emphysema that might be testable on the boards. So pan-acinar is associated with alpha-1 trypsin deficiency, which can also cause what? Well, you also see it in the liver, so liver cirrhosis, where the patient is typically younger and not a smoker. And then there's erysipetal emphysema, which is frequently the cause of spontaneous pneumothorax due to bullae rupture in tall, thin adolescent males. We'll get to that later. So how is asthma different from COPD? Asthma is classically associated with bronchial hyperresponsiveness, where you get reversible bronchoconstriction, whereas with COPD, the obstruction tends to be fixed. Now remember, there's a spectrum where you can have a bit of overlap between these two conditions. The classic pathology associated with asthma is smooth muscle hypertrophy, airway inflammation, and mucus plugging. Kirschmann spirals are shed epithelium that is a byproduct of the mucus plugging. You can see the obvious corkscrew shape here. Now, if you looked at the sputum of an asthma patient, what else could you see? Well, you might also see Crayola bodies, Charcot-Leyden crystals, and of course, eosinophils, especially in allergic asthma. These are interesting and classic findings in the mucus, but we don't use them in the routine diagnosis and management of asthma. Now, what is useful is knowing about the patient's asthma triggers. These can include infection, allergies, stress, exercise, smoke, cold weather, occupational exposure, and so forth. And here, of course, are the classic hallmark findings of asthma that you might see on the exam. Finally, we come to bronchiectasis, which is basically a permanent irreversible dilatation of the proximal and medium-sized bronchi. Patients with bronchiectasis may present with purulent sputum, recurrent infectious, and hemoptysis. And how do you get bronchiectasis? Well, causes of this condition include necrotizing infections with bugs like Staph and Klebsiella, bronchial obstruction, cystic fibrosis, poor ciliary motility, Cartagena syndrome, and allergic bronchopulmonary aspergillosis.